Thank you for joining us for our webinar today. Let's see. Oh, no one needs to announce who they are, but thank you, Jessica. Thank you for joining our webinar, Unmet Needs, Complex Motivations, and Ideal Care for People Using Fentanyl in Washington State, a qualitative study. I'm Alison Newman here at the University of Washington Addictions, Drug, and Alcohol Institute. I'll let Everett and then Teresa introduce themselves.
Hello, everyone. Good afternoon. Thanks for joining us. I'm Everett Maroon, Executive Director of Blue Mountain Heart to Heart in Walla Walla, 501c3 that does work with substance use disorder. And this is actually part of my practicum requirement for the Masters in Public Health program at UW. So I've been very honored to work with Alison and Teresa on this. They're wonderful, brilliant mentors.
It's been great to have you, Everett. I'm Teresa Winstead. I'm a research scientist with ADAI and also an associate professor of anthropology and sociology at St. Martin's University. So sort of doing both work with ADAI on this project and also faculty at St. Martin's, and just has been really gratifying to work on this with Alison and Everett.
So just the intro to the platform we're on, we're using Zoom webinar, which means we can't see or hear you, and that only panelists can share their video and audio. We encourage curiosity and discussion, so enter your questions into the Q&A and comments into the chat and keep it respectful. We'll answer questions at the end of the presentation, but we'll keep an eye on the Q&A and the chat in case something comes up where you need clarification. The presentation is being recorded and slides will be posted. They're actually already posted on the report webpage in Prezi, so that's something you can navigate on your own after the fact. And this last bullet is just because this happened one time, but if you're a journalist, let us know if you plan to report on this presentation, send us an email. We just like to know so we can keep track of sort of where people are learning about us. And there's no need to enter who you are into the chat, but if you want to, you certainly can. So I'm gonna hand it off to Teresa to start us off.
Thank you, Alison. We are glad to have you here, all of you that are here, to think with us about the impact that fentanyl has had on and continues to have on Washington State residents. As Alison mentioned, we're bringing you this research involving people who are currently using fentanyl, with the hope that this analysis and our participants' insights and experiences that they shared with us will help inform more nuanced and holistic approaches to this public health crisis and help inform, importantly, concrete improvements to the well-being of people who are currently using fentanyl. I'll be talking about the scope and the methods of this project and share kind of the basic population characteristics, and then hand it over to Everett and Alison, who will share a summary of our findings and our recommendations. If you have any questions about what I'm talking about at the beginning here, save them up for the end. I'm happy to elaborate, but I'm going to try to move quickly through these details. So the partners that we worked with, the kind of first thing we want to do is thank our partners wholeheartedly, because this project wouldn't have been possible without their participation and their support. So lots of appreciation for them. Interviews were conducted across these 4 sites in Washington, and they include the Clallam County Harm Reduction Health Center in Port Angeles, the Tacoma Needle Exchange in Tacoma with 2 sites there in Tacoma, Thurston County Syringe Services Program in Olympia, and the Spokane Regional Health District Syringe Services Program in Spokane. So huge gratitude to both the partners and the participants at those sites for hosting us and for sharing their experiences and insights. The background, of course, to this study is opioid overdose deaths, which in Washington continue to rise and are primarily driven by unregulated fentanyl. From 2019 to 2022, the opioid overdose death rate in Washington nearly doubled. And in 2022, fentanyl was involved in 90% of opioid overdose deaths in Washington State. So the emergence and dominance of fentanyl over heroin as the primary opioid in the illicit drug supply has fundamentally changed the context of opioid use, has increased risk for those that are using fentanyl, and intensified the need for modified social and medical supports in response to this crisis. So that all sort of underscores what we feel like is the importance of this work, this qualitative project where we're sharing the voices of people who know the most about the landscape of this crisis to help better inform strategies and prevent these numbers from continuing to rise. So I think we had a link to that data shared in the chat. So just to note that that's available on ADA's website. This work is also connected to other projects that have been ongoing at ADAI, partnerships with Washington State Syringe Service programs, notably the biannual survey of syringe service participants that happens every other year. This project is the third set of qualitative interviews in this series, and of course focused on fentanyl because of the primacy of fentanyl in overdose numbers currently. The approach to this work, we want to mention, just to give kind of a framing to what we'll share with you. The project was informed in its aims, approach, and design by the principles of harm reduction. We are seeking to inform policies and decrease harms of fentanyl use by engaging with people who naturally know the most about their needs and what might work to improve their wellness, really emphasizing that their insights are valuable and important. The interviews were exploratory and semi-structured, designed with trauma-informed communication in mind and fostering dialogue with care, respect, generous connection, and compassion. So really thinking about how we meet people where they're at and support them, find out what's happening for them and what can improve their wellness. Thinking about all of these principles, the topic areas that we focused on in the interviews. Alison, if you'll advance the, thank you. The topic areas in the interviews include questions about treatment history and experience. So what folks had experienced before, their fentanyl use and other substance use patterns, their motivations for and the drawbacks of fentanyl use from their perspective, their relative interest in stopping and reducing fentanyl use, and the preferred services and ideal care that would support their wellness. So a lot of topics, and we'll share an abbreviated summary. You can find the full report, of course, on the website. And then getting into a little bit more of nitty-gritty methods. And again, I'm trying to go a little bit quickly here. The interviews themselves took place between September and October in 2022. We completed 30 semi-structured interviews across our programs that I mentioned. The participants for this study were offered a small gift card as an incentive, a Visa gift card, $25. And we also had snacks and drinks for them as they talked with us about their experiences and perspectives. We audio recorded those interviews and transcribed them with a HIPAA compliant transcription service. And then the research team verified the transcripts before we started coding. The coding that we use to provide you this synthesis of the interviews was a combination of structural coding based on the protocol questions, deductive coding based on what we knew we were interested in already, making sure that we were identifying, and inductive coding based on what emerged from the interviews themselves. That analysis and coding was assisted by Max QDA, qualitative data analysis software package. And we engaged in a lot of collaborative, sort of iterative, responsive meeting throughout the, and discussing throughout the process to make sure that we were on the same page with our analysis across the research team. We then shared the results back with sites before the official report was released to elicit feedback from our host sites. And we created a handout for participants to share the research with participants. Because we didn't collect any identifiers at all, we wanted to provide that for the sites to have on hand in case anybody that participated wanted to know what our results were. Then just a little bit about screening criteria. We worked with the sites to identify potential participants, and in order to participate, folks needed to be a current syringe service participant, 18 years or older, having used fentanyl at least 3 times in the previous week, and also identifying fentanyl as their main drug. So those were the things that helped us create kind of a set of screening questions for participation in the interviews. I'll talk a little bit about population characteristics next. These are good things to keep in mind as you listen to the findings from Alison and Everett that we're just getting to right here in a minute. A quick mention of the geography of our sites, just in case you're not familiar with Washington State geography. We had 14 participants in Tacoma, 8 in Olympia, that's in the kind of urban corridor there in the center of the state. Port Angeles, 4 participants up in the corner there at the top, and then 4 participants in Spokane. And the interviews, I think I haven't mentioned quite yet that they typically took about 30 to 60 minutes. So just a brief kind of mention again of demographics. So you have these in mind as you're listening to findings. Over half of our participants reported white as their racial and ethnic identity. 73%, as you can see here, were male. The mean age of participants was 37, and only 13% of our participants reported having stable housing. So that other 86% were housing insecure, 73% were unhoused, and another 13% unstably housed. So just having that in mind as you're listening to findings is good. Then fentanyl use, this next kind of piece of demographic and substance use basic information here. We asked folks about their frequency and duration of their fentanyl use. And you can see in the chart here, the vast majority were using fentanyl every day and had been using fentanyl on average of about 13 months. So nearly all participants nearly all participants were using other substances in addition to fentanyl use, which is relevant for our kind of thinking about overdose numbers. So moving on to just this last little bit about treatment history. You can find more about treatment history in the report itself. We're just going to mention this very briefly today. We asked participants what kind of treatment they had previous experiences with, and 2/3 of our participants had tried some kind of treatment, with the majority of those responses having tried non-prescribed buprenorphine, so buprenorphine from outside of a medical encounter from a friend or from another source. Responses about traditional treatment, inpatient and outpatient treatment kind of experiences were mixed and often negative. And again, more in the full report if you're interested in what people said related to that. And I'll just share one participant's perspective. And he was expressing his frustration with accessing treatment during actually the very last question that we asked in the interview. We asked what else we need to know about supporting people who are currently using fentanyl. And in response to that, he said, when they do get sick and they say they're sick, take pity on them. Don't say, come back tomorrow. That's a million miles away. Do something, help them, and tell them that's it. And this is kind of underscored by what he shares next, his own frustration accessing treatment. He says, I take the bus to the methadone clinic and I was 15 minutes late and the provider wouldn't give me my dose. I thank God that she didn't give me my dose because I'd rather take drugs. So that's one kind of piece of the puzzle here. And again, if you're interested, you can look at the full report for more on treatment experiences. Now I'll hand it over to Everett, who will talk about perspectives on why people use fentanyl, and we'll go from there. Thank you so much.
Thank you, Teresa. I'm going to talk a little bit about the why fentanyl, which we have framed into motivations and drawbacks. So if you go to the next slide, so when we're looking at how people use fentanyl, most people smoked as opposed to injected fentanyl that we spoke with. Some folks had told us that they had previously used heroin and they had already been injectors, but in the move to fentanyl, they changed their method of use. And what we heard from them were it's easier. And we heard the sense that it reduces overdose risk. So there were many moments in these interviews where we could really hear pretty clearly from our respondents that they were trying to mediate overdose risk. They were concerned about the risk to their own health. So even in an environment lacking in care, where they might not be accessing treatment, they were still focusing on, supporting their own health and protecting themselves. And the other main issue that we heard about in the interviews, and again, there's more detail in the report, was this big supply shift. There was one person who even said, I can tell you exactly when the supply shift went from heroin to fentanyl, and it was in March of 2020. So literally at the beginning of the COVID-19 pandemic, as everything was changing, one of those things that was changing for people was what was available in the underground drug market. So it happened very fast, and people who shifted found that it's been a permanent shift due to the potency and withdrawal intensity of fentanyl. Next slide, please. And here's a pretty typical response that we heard from people, that moving to fentanyl was a movement to smoking, and then also changed the frequency of use for them. This makes some sense because fentanyl's half-life is much shorter than heroin's in general, and so withdrawal comes on more quickly, and then they're trying to manage that. Okay, so we'll go into and then this is the other issue that we heard about. People are nervous about their risk of overdose, and so smoking lets them consume a bit at a time, whereas there were some other quotes in the interviews where they said that once you've injected it, then there it is in your system. At least with smoking, I can kind of control how much. And that's a great quote here. I'm not looking to die. I'm just looking for some pain relief. Okay. Again, more comments about how I should have just stuck with heroin because I wasn't dying from heroin. So there were some people who definitely did tell us that they enjoyed and sought after the high that they got from fentanyl in particular, but there were also many people who really were not great fans of the intensity of fentanyl compared to heroin, and then what it meant for their lives. So, all of a sudden one day I was just addicted to fentanyl instead of heroin. It was weird. And then I tried heroin again, and it didn't do the same thing for me. So this supply shift has a strong, robust effect that continues for people and helps drive use. Next slide. So in looking at motivations and drawbacks of fentanyl use, we're going to start with physical pain. 70% of respondents mentioned pain as a motivator for use. And one of the things I'd like to think about and talk with you about, and have you, if you have questions about this, is really look at the complexity of motivators. They really ran the gamut from negative and positive reinforcements with dependencies between them. We're going to look at these one by one. So when we pick up with physical pain, we heard in the interviews that pain presented either as an antecedent to fentanyl use or as a consequence after use began. Many people said that fentanyl helped them function, and I think we have a quote in here about that. That helped them function through pain that they were having, chronic pain. Some suggested it controlled pain, and some would have preferred a proper medication but lacked access or trust of a physician. And we did hear from more than one respondent that many of them had been on some sort of prescribed narcotic and then been cut off by their provider And what they were left with, after the shift from heroin to fentanyl was just street fentanyl. But that they still had a chronic pain issue that needed attention. And so this is what they were doing to manage that. Um, they there were a couple of people who suggested that there was pain that happened after their fentanyl use, but that fentanyl was itself at that point still a means of controlling the pain that they had. And it could have been like pain in their feet. Someone talked about leg pain. There were other kinds of pain that we heard about. This last quote was the last quote was from someone that I talked to who said, if I could just get some pain relief from the doctor. So I think there is a larger issue here about how healthcare is handling pain control. Thanks, Alison. Next slide, please. Mental health. This was observed as both an issue prior to and because of fentanyl, just like with pain. And sometimes both occurred for the same individual. So they had a mental health issue. They found that fentanyl helped them address it to some degree. And then they found that fentanyl was either causing or not fully remediating whatever mental health issue they were documenting with us. And we heard a lot about how it would help sort of numb them either from the trauma that was involved in their substance use at all, or due to the fact that, at this point, maybe they were unemployed, maybe they were without housing. So I seek it out to numb myself, basically. I think that there was a lot there that similarly to pain control, people talked with us about not finding adequate support for mental health from traditional providers. And so fentanyl then came in as one way to help do that. And another note I wanted to make was at least one respondent also told us he saw fentanyl cause people he knew to do things he'd never known them to do before. So there was this very complicated relationship between how they felt fentanyl helped them in themselves address mental health issues, but how they also saw fentanyl negatively impact the behavior of people that they knew. Next slide, please. So homelessness. Who'd be sober and live out here? Fentanyl use is an activity that helps people trying to survive without housing feel better about their situation. We heard this from several different people. In this way, we saw that homelessness drove people to continue using, even while the popular understanding might be that people who use drugs don't care that they're homeless. So really quite to the contrary of what might be sort of a societal expectation here. Some people want to be homeless. I certainly hear that a lot in Walla Walla. The homelessness might be due to fentanyl use, but once they're without housing, fentanyl use helps them manage the fact that they're without housing. And you can kind of see these tensions in these quotes here. It makes it to where you don't feel the bullshit. You don't care. You don't care about none of this. You don't care about it. It helps. But then we also have people saying, well, I really wasn't homeless until I had to use fentanyl all day to avoid withdrawal. So homelessness is a motivator and also, detractor for people. We could go to the next one. Withdrawal. The well-known potency of fentanyl brings on extreme or severe withdrawal symptoms and quickly compared to other opioids. Respondents explained that this effect, coupled with limited treatment availability, worked against them stopping. So withdrawal, really was something people were trying to avoid, especially when they don't have housing and they're just in public experiencing the symptoms of withdrawal. So as they said, the fear of sickness is it's not fun. It's not something anybody wants to go through. So withdrawal avoidance really becomes a main motivator for continued use. And then we had two big drawbacks that we heard in these interviews with folks. These presented as real concerns for the people that we talk to. They're generally very aware of the risks of using fentanyl, but the motivators are very strong. Without external support, they manage by trying to control their dosing, learn more about what they're using, and use more cautiously. So overdose risk was definitely on front of mind for many people that we talked with, where they would say things like, I'm a prisoner to this drug. I can't do anything except fentanyl. And some people didn't even really like the high that they were getting in this quote here. It's not as euphoric, I guess you could say. But the quote then moves into this concern, right? That there's very little maneuverability room between, having the euphoric effect that you're looking for and overdosing. This makes people somewhat reliant on what they think are safer sources for the substance that they're using. I think we have another slide after this, variability. Yeah. In an underground drug market and one affected by a global pandemic, where there are new suppliers on the scene, our respondents were very unsure about what they were getting when they were purchasing fentanyl for their use. So they understand that a pill can vary in strength from one side of the pill to the other side of the pill. And this quote here, whether it's cut because on purpose or just on accident by how it's stirred together, and people with low tolerances aren't used to it. I think that was probably something that changed behavior for many of the people that we talked to. I don't recall prior to fentanyl being on the scene more generally that people were particularly nervous about tar heroin. I remember one person coming into the syringe exchange one time and saying, "We don't even get good heroin in Walla Walla." It was interesting to go through the interviews and hear about how people were trying to mediate this risk and understand that what they were receiving might not be the same in terms of quantity, quality, or response in their own body from one day to the next. So a little bit more generally, the consequences of fentanyl or the drawbacks of fentanyl cause big changes in people's lives quite quickly. We heard about negative effects on their relationships. Some respondents stayed away from their loved ones due to a perception that they were now an embarrassment to the people that they knew. Supportive workers who come into contact with people who are using fentanyl should question if the client has alienated themselves from social supports and ask about their relationships. Saying things like, fentanyl has really gotten in the way of my tasks and obligations is an interesting counterpoint to the folks who said things like, fentanyl helps me control my pain so that I can see my grandkids. There's definitely a situational variability for people, but the fact that it is a very big effect on their relationships and that it can take away their support systems was pretty clear from our interviews. I think that's my last one, or is there another one? There you go. Thank you. Now it's you, Alison.
Thanks so much, Everett. So I think Everett and Teresa did a really wonderful job laying the groundwork for what people's lives are like. And that's a really big piece of this, is describing the texture of people's lives and understanding people's reasons for why they're doing what they're doing. So we did ask people, how interested are you in stopping or reducing your fentanyl use? This is a question we've asked on our syringe services program survey in the past. In this particular case, 70% of people said that they were interested in reducing or stopping their fentanyl use. 27% said they were not interested, and 3% said they were not sure. And this is pretty in line with our past syringe services program surveys, where a large proportion of people who used opioids said they were interested in reducing or stopping their use. So given that most people would like to stop or reduce their use, what kind of services are they interested in? We wanted to know, given why people use, what kind of things would help them. We asked them about specific services and ideal care. And some of the big takeaways from that are that people wanted a range of different physical and mental health services and help with basic needs. And that what's most important, care that's accessible and non-judgmental. And we'll get into that a little bit more. So about halfway through these interviews, we pulled out this long list of different services and asked people what services would you want if they were easy to get, and asked if they were interested, not interested, or not sure. This is definitely something you can check out in more detail in the report. The big summary here is people were very interested in different services to meet their basic needs for things like housing, cash assistance, employment support, phones. Also interested in harm reduction supplies. I think pretty notably, people were very interested in contingency management for their fentanyl use. And the area where people were the least interested in kind of things was in more traditional substance use disorder counseling. And just need to make a note that no one knew what one-on-one harm reduction counseling was, which is why we put an asterisk right there. But another big takeaway is people are really interested in a lot of different things. So it's important that we make sure that there is like a range of things that people can try. So we asked people to describe your ideal place to get help with your health and or substance use, and then ask them about some specific domains around that. And some background is we really wanted to talk about care versus treatment. Treatment for many people is like a very loaded term and has a specific connotation. And we wanted to know more broadly than treatment, what kind of things people thought would help them. As far as services and supports, people wanted physical health care, mental health care. It needed to be accessible in terms of location, cost, access, hours, things like that. People wanted a place that might also provide a sense of purpose or activities that were an alternative to using fentanyl. People wanted help with basic needs. A few people talked about wanting access to safe supply. And a few people talked about wanting transition supports. So something that could help them reintegrate if they did stop using fentanyl. And I really like this quote because I think it gets at a lot of what people talking about. Someone described wanting just a place where you can calm your mind and relax and kind of be at peace. I think a lot of times, a lot of people, myself included, cannot be comfortable in the world or in our bodies or experiencing life. So just a place, a reason to be more comfortable with that, with less drug use or dependence on substances, to have that comfort, I guess. So we asked people, if in this ideal place, who would the providers be? Who are the ideal types of people that you'd want to have helping you? And people talked a lot about, having mental health counselors, physical healthcare providers, social workers, and what came up most frequently was having staff with lived experience. So someone said to have somebody who's already been through it to show us that there's light at the end of that dark tunnel. And this came up really frequently throughout these interviews. People really wanting someone who understood their situation, was not going to judge them, and could be compassionate. And sometimes that came up in contrast to what people had experienced previously with different care settings or different treatment settings where maybe they hadn't had a good experience, had been judged or not treated compassionately. So I think this is a nice summary. Someone said who would work there: a psychologist, a doctor, the staff members, secretary, and the clinical workers, social workers, providers. And I think what that captures is people really want like a one-stop shop with a mix of different people who can help them. So we asked about the physical location, what that would be like. We asked what the vibe would be and what the rules would be like. Many people describe wanting care in a homey space or a cozy space. I think several people use the words cozy and contrasted it with more like a rigid, cold, or sterile environments. People wanted the place to be easy to get to and have flexible hours. Said it's really important that it be somewhere that you can easily get into, you don't have a long wait, and that it shouldn't have rigid rules. Some people talked about the benefits of having rules and guidelines as a way to sort of guide them, but other people talked about really the big drawbacks of being kicked out of a program if they either had a recurrence in use or broke other rules. So having rules that are, accommodate people and are flexible for them. This one person said, that's not like a facility, but not an institution or something, but I don't know. I would just think a place should be like a house. You know what I'm saying? So you feel like you're at home. And I think this is a really evocative quote. Nobody's going to do it unless they really wanted to. So there's no need to be so pushy. So really that motivation has to come from that person. And then this quote was referencing the vibe. It says the general vibe would be acceptance and love, and you don't have to hurt yourself to not hurt here, because all of that is hurting yourselves out there. You're safe here. So having a space that's really, for many people, homey, or a few people wanted care at home. One person wanted care, like actually two of the people wanted care at home with their families. And then having a space that is like really accepting, a vibe that is, safe for people. So we did also ask people about the medications for opioid use disorder. There's a lot more about this in the report, and it's a complex topic. I'd say people were generally interested in methadone and buprenorphine, but perceived really significant barriers to accessing those. Methadone, especially, people talked about how difficult it was to have to go every day or to travel very far to obtain methadone, and that a lot of the rules and regulations around it meant that it wasn't really an option for them. One person said, if they had a methadone clinic closer to my home, I wouldn't have to drive an hour and a half, 2 hours every day to get to it. Or if they gave out a week doses at a time, that'd be cool. Another person talked about wishing that methadone was obtainable just like any other drug at a pharmacy. So they would try methadone if they could just get it like any other medication at a pharmacy, but they weren't interested in the different things they would have to do to access methadone the way it is now. A few people mentioned concerns about buprenorphine causing precipitated withdrawal for fentanyl use. People were unsure whether it would be a good medication for them for fentanyl. Many people had tried it previously, but that was more common for heroin. And many people talked about wanting to try a medication, but as a way to not be on anything at all in the future. So this person said, because the key is to not have to use anything else out there, and eventually maybe not even need to use some of the things that are here, the Suboxone and stuff, but that's one step at a time. So I think one of the takeaways from this section is that there's really serious barriers to people accessing these medications, and that for Suboxone, there may be a need for increased education for this population about Suboxone, and also, figuring out what might really work for this population. So that was our section on ideal care. There's so much more in the report. I think it was really wonderful to have the opportunity to ask people what they thought would work for them, which isn't something that we always do in healthcare. And it felt really great to be able to ask people what they thought would really be effective. So what are the big things that we learned here? I think Everett and Teresa highlighted a lot of these, but in our conversations as we were developing this report, it kept coming up like, how is this any different? How is this different than heroin? One of the things is that people reported a huge shift in the drug market from heroin to fentanyl around 2020. This really affected them pretty hugely. A big summary of how it affected them: people are really afraid of overdose and dying. And this came up a lot more than it did in previous rounds of interviews that we did. I did interviews in 2018 and 2021, and overdose didn't come up all that frequently. But in this situation, people talked a lot about overdose and dying, and having known many people who had died from overdose. So this is a group of people who are experiencing, deaths of friends and loved ones really frequently, and that is really affecting them. Another big shift is the move from injecting to smoking, and the perception that smoking is a way to reduce overdose risk. I think it's really important to note that, in Washington and in other places, a large proportion of overdose deaths do appear to involve smoking. So we know, it's still possible to die from overdose from smoking. So we really think future research should dig into how to keep people safe from overdose when smoking and how to educate people about the potential risks of smoking. I think the biggest thing we notice is that gap between what people need and what's available is really wider than ever. And it's even more critical that we really address it as quickly as we can. Fentanyl exacerbates all the things that are challenging about opioid use disorder due to its potency and half-life. And we still haven't built a system where everyone who wants care is getting it. People talked about how it's easier to continue using fentanyl rather than access treatment, and that barriers to entry are high and options are often very limited. Just driving home again that people have really complex reasons for using fentanyl and multiple motivators, which really suggests they may need a range of supports and services to address these. Many people expressed not feeling like they could stop using fentanyl until either their physical pain was addressed or their homelessness or some other component of what was driving their use. So really important, most people wanted to reduce or stop their use, and everyone was taking steps to avoid overdose and stay alive. This is, people expressed not wanting to die. I think that's really important. People really are doing a lot to try and stay healthy and stay alive. And there's a lot that we can do to further promote that for them and make that easier. So we think that appropriate and accessible care could have a big impact on improving health and reducing overdose deaths. So what does this ideal care look like? It would be holistic, meet people's basic needs, be easy to access in terms of cost, location, hours, rules, be non-judgmental, and provide accessible medications for people who want them. And one thing we talked a lot about that became really clear from this is we need to even further work on engaging people when they're ready for services, not just when they're ready to quit using fentanyl. So move toward a system of ongoing care and health promotion versus a system of treatment that's focused on abstinence. So recommendations, treat fentanyl as a serious public health crisis. It's really just gotten a lot worse, and people describe pretty dire living situations. The people we spoke with are experts on their lives and are really insightful about what would help improve their health. That we think health programs should be accessible to people who use fentanyl, either in hours, cost, staff, compassion. We also think programs should work to meet people's basic needs, since at least with this group of people, it was really driving their use. We'd like to see more programs be able to provide safer smoking supplies as a way to engage people who use fentanyl and also as a way to help support their health. It's really important to increase access to education about medications for opioid use disorder. Access to and education about medications for opioid use disorder. So make it easier for people to get these medications and ensure that they really have a good understanding of what the medications can do and how they work. And then consider safe supply. The people we spoke with were very aware of the variability of fentanyl and the challenges that posed in terms of both if it was too weak or the really serious risks to their health and life if it was too strong. So consider safe supply if we want to try and save lives. So there's a few limitations from the study. It's a convenience sample and may not be representative of everyone who uses fentanyl. Part of that is, the majority of people we spoke with were unhoused, and this may not be applicable to everyone. The majority of participants were men, And the interviews were conducted in Washington state and may not be relevant in other parts of the country with a different substance supply, like drug supply. So this is our big thank you. We already said thank you to all of our wonderful partners. Also want to thank DBHR for funding this work, and then Everett for being our student on this project. And just a shout out, this is our summary for SSP participants, which is certainly something you can share with the general public. And then if you want to learn more, these are all the links and you can email us. So good, I ended right on time and we have plenty of time for questions. So enter your questions into the Q&A as you have them. Oh, good question from David. And Everett and Teresa, feel free to unmute and hop on. David's question is, did you find out why 27% were not interested in stopping or reducing fentanyl use?
Yeah, I mean, it's complicated. I think some of our participants, were clearly, they expressed that they were fine with the way that their use was, right? They said they weren't interested in stopping, that they didn't feel like their use was problematic right now. That was a small percentage of that group, very small number, expressed something like that, I think 4 maybe. Other folks, consistent with what Alison shared and Everett about our findings, said that they just didn't feel like it was possible for them to stop, right? No options. So they were like, no, not going to happen.
Everett, is there anything you'd want to add?
Well, I was just going to say, I think one other thing that I think I heard was once people had a negative interaction with a mental health or healthcare provider, that tended to persist for them, in presuming that future encounters would also be negative or stigmatizing. So kind of goes to what we can do to educate providers around how to serve people who are, needing support and not letting unconscious bias or stigma get in the way of that.
I'm going to answer a question that's in the Q&A. Fascinating insights. I'm curious about the high rates of co-occurring meth use. Is this a recent trend or was meth use common with heroin as well? Also, did people report meth use complicating their OUD recovery? And I can answer that, which is that heroin and meth, were pretty common. We found that in our syringe services program surveys in the past. So that's not a new thing. And that it can complicate people's recovery. So that's one thing that has just continued. Methamphetamine is really widely available in Washington, and there's been a lot of concurrent opioid and methamphetamine use, and it can make it harder for people to stop using.
I also think for that other question, what are the barriers around getting safe smoking supplies? That has just changed in Washington state with the passage of SB 5536. And Alison and Teresa will absolutely correct me if I'm wrong. But as of July 1, we can more clearly distribute safer smoking supplies and test strips to the public. There's also an allowance in that law for municipal authorities to be able to regulate that kind of activity, even to the point of banning it in their jurisdiction. So, we're going to have to see how this all plays out. There were a couple of places distributing safer smoking kits prior to July 1. My agency was one of them. But now I think there's more of an open pathway. And so I think we'll start to see some more guidance come out around what to put in those kits and what kind of support, financial support there will be for agencies looking to do that.
I have a question that I can answer. The question in the chat is, have you heard people state that fentanyl can cause joint agitation? And I have not heard that. If people listening have heard that, feel free to answer. I don't know, Everett or Teresa, did you hear that at all?
Not in
No.
these interviews and not in other places.
And then we have a nice comment from Becky Starnes. Sounds like this really supports the need for health hubs.
Yes.
It did seem like that. People really wanted one place they could go and get help with all sorts of things, and a place where they could go and not feel judged. And some people just wanted a chill out space. So
Yeah.
just a place to be. I have a question from Lee. How would you educate people on the risks of smoking fentanyl when it's perceived by some as being less harmful than injecting heroin?
Is where I want one of my staff members to pipe up.
Yes.
You know, I try not to just, confront someone and say that they're wrong if they're in front of me and they're looking for support from me or my staff. Um, there are other things that we can also recommend to people, such as not using alone, always having naloxone on hand, training them in how to identify opioid overdose and respond using naloxone. Sometimes there are apps out there, or people will have a call arrangement if they're going to use by themselves. So if you don't hear from me in 10 minutes, then check on me. We don't necessarily have to go to your perception is wrong, but acknowledge that where you're in agreement with someone. So if they're concerned about overdose, mirror the concern. If they're concerned that their underground supply is very variable, I think we can all agree that that is an issue. There is a drug checking effort underway also through ADAI in Washington State. There are several sites now that are using mass spectrometers to look at, what might be contained in those samples as presented by lay people. So these all just kind of generate conversations that to have with folks to try to, help them reduce their risk. And there are also a lot of different handouts out there from Harm Reduction Coalition, other providers, and UW themselves that we can supply to people so that they can read on their own time and, start to educate themselves. But I definitely would not just go up to someone and say, yeah, definitely return to injecting. It might not be the case that smoking is going to really lower their risk, depending on a whole host of variables that we don't know. But it's good to have the conversation about trying to reduce the risk.
I have a question from Edwina. How many people were homeless families were interviewed? At Mary's Place Shelter, we have an increase of parents who use and are babies born with drugs. I don't know that we have that number.
We didn't track people that were parents. We did have some folks talk about their kids and dynamics around kind of tending to themselves and their children, along with the complexities of fentanyl use right now. But that's not something that we tracked specifically.
And I have a question from Carly Laney. CODA is doing research on the use of Sublocade for people who want to stop using meth and occasional fentanyl use weekly. Have you heard of the use of Sublocade for both meth / OUD? And I have heard of the use of it for fentanyl. I haven't heard of the use of it for meth, but I'm not. What's that?
I was trying to find the question.
Oh, it's the use of Sublocade for people who want to stop using meth. I'm not familiar with that, but it doesn't mean it's not happening. And if Caleb Bantagreen is on this call, please enter a response in the chat.
I've definitely heard of Sublocade for OUD, and I think it's especially valuable for people who are releasing from a controlled setting like inpatient or jail setting or prison. But I can't say that I know anything about its use for meth dependence. That's really my focus has been on OUD response. We've had very good results so far with contingency management in our programs. I'm happy to talk about that offline sometime. I think it's a different topic, but incentives can go a long way um, for people who are motivated.
We have a question from John. Was there a reason that the largest city in Washington state did not have a facility that participated? And I can answer that, which is that for our qualitative interviews, we've tried to focus on areas that may not have the resources to do their own qualitative research. And King County is really fortunate to have some pretty wonderful epidemiologists and researchers who work with them who can do this kind of work there. So we wanted to focus on energy and resources on smaller places that wouldn't have been able to do a study like this on their own. Any other questions?
Or points for discussion.
Or points for discussion, either one.
Yeah.
Candace asks, big picture question, wholeheartedly agree that safe supply is a North Star we need to be working towards, but how can we get there? Feels so out of reach in environments where we are continually battling, even providing basic harm reduction programs and maintaining funding.
Yeah, Candace, I hear that.
Yep, absolutely. The challenges are really big, for sure.
I don't think I have a good answer for the how do we get there, but I think we can start by documenting that people want to stay alive, that they don't like that fentanyl is variable, and educating policymakers about those points.
And I think there's something to be said for, continuing to talk about how the unregulated supply puts people in this kind of really dangerous position, right? And that this is a public health crisis that requires a response, and that even the strategies that we have are not adequate for keeping people safe. So the drug supply is so dangerous that all of the resources we have right now, except for just telling people not to use fentanyl, right? Which we know doesn't work, cannot help people know what's in their substance and make choices to avoid overdose, because the supply is so variable and dangerous. So I think continuing to talk about that and bringing attention to that with all of the work that that is being done in this area is really important. I think that's like as close to we can come as to an answer or moving that direction.
And the more people who are out there in the field doing work for folks and working in their communities, speak up to your elected representatives. We clearly have a legislature that has a lot of different ideas and is not of the same mind on drug policy for all of us residents in the state. So, the more that they can hear from people who are actually out there in the field, who have really just the goal of supporting the humans in front of them, the better we're going to get to drug policy that makes more sense for more people.
I think one other big takeaway from this work is that people really are feeling very stuck, and that we have a lot of misconceptions about what people that are using fentanyl, what their perspectives might be. And I think one thing that this work contributes is a very clear message that people would like options to increase their wellness and decrease their fentanyl use and stop their fentanyl use, and that those options are not available to them.
I think that's a great summary note. It is 3:00. I just want to thank everyone for attending. I want to thank the programs that worked with us on this project and all the participants who gave us their time and energy and expertise and knowledge. And just thank you all for attending. We'll be sending out a link to the slides and this recording probably in the next few days. Please send us any questions that you have, and just thank you all so much.